Hello, everyone. This is your host, Mehak Shah. Welcome to a new episode of the Heart Success Podcast, where we discuss practical knowledge and the latest in the field of cardiovascular medicine. My main interests are in the field of heart failure, cardiac hemodynamics, pulmonary hypertension and right heart failure, mechanical circulatory support, thoracic solid organ transplantation. We will be spending the first few episodes discussing these topics. All listeners be advised that the podcast is for personal information, education, and entertainment only. Information from this podcast should not be used as medical dictum, and all decisions related to patient care should be made in consultation with care providers. In our second episode today, we decided to tackle the right ventricle. We're going to talk about right ventricular failure and recognition, diagnosis, testing, and management of patients with acute right ventricular failure.
We have Dr. Sandhya Murthy with us today to discuss management in acute RV failure. Dr. Murthy is a board-certified advanced heart failure attending currently at Montefiore Medical Center in Bronx, New York, with special expertise in management of pulmonary hypertension and RV failure. Dr. Murthy actually finished her medical education back at UMDNJ and then did a residency and fellowship at Montefiore Medical Center, cardiovascular disease fellowship, and then went on to Columbia Presbyterian Medical Center for her heart failure fellowship following that. Welcome to Heart Success, Dr. Murthy.
Thanks so much, Mehak. It's great to be here with you.
Thanks, Dr. Murthy. So before we start, just so that our listeners get to know a little bit more about you, could you tell us a little bit about what you do, what your daily routine is when you're not working?
Oh, boy. Well, I have 3 little kids, so it's really hard to have any kind of personal routine when you have that. But I guess I should say I recently got into the Peloton, and I'm obsessed with along with everybody else, I guess, that has it. And that's been my lifesaver outside of work.
Nice. And so we'll just start talking about the right ventricular failure aspect of things. And I'm going to start off by describing the right ventricle for our listeners and how it differs from the left ventricle. Anatomically, the RV, as we know, is very different from the left ventricle. The RV is thinner. The free wall is roughly 2 to 3 millimeters. It is a more compliant chamber than the left ventricle. And typically, if you look at the echocardiogram and you look at your images, the RV is crescent-shaped or hemi-ellipsoid shaped compared to the left ventricle. The RV anatomically also has other differences. Largely, it has a heavily trabeculated ventricle, but a fairly smooth sinus for venous inflow and tubular outflow. It also differs from the left ventricle because it has a separation between the tricuspid valve and the pulmonic valve called the crista supraventricularis, which is sort of a muscular separating anatomical structure. On the other hand, in the left ventricle, you have sort of anatomic continuity between the mitral valve and the aortic valve. Embryologically also, the right ventricle is different because embryologically, when you start out, you have the primary heart field and the secondary heart field. The left ventricle comes from the primary heart field, whereas all of the right ventricle, part of the septum, and the roots of your aorta and pulmonic arteries come from the secondary heart field. So that's sort of a little bit of a difference going in the anatomical aspects of things. As you can imagine, the RV is also functionally and physiologically different from the left ventricle. So Dr. Murthy, could you tell us a little bit more about these differences that we encounter in clinical practice when we're dealing with the right ventricle?
Yeah, absolutely. So, you described it perfectly. Basically, the RV and the LV come from different parts embryologically speaking. So you really need to think about these two chambers really dramatically differently. So I'd like to think about RV function as basically 3 broad categories. One is, you can think of it as intrinsic RV function, which is pericardial compliance and the actual muscular part of this. The second thing is preload. Preload for the RV is venous return. The third thing is afterload, which if you think about what exactly is the RV pushing against, it's pushing against the lungs. And the lungs are a normally pretty low resistance, highly compliant circuit, unlike the systemic circulation, which is a little bit higher resistance compared to the lung vasculature. So it's always, it would be remiss not to talk about the pressure volume loop, because that's really describes perfectly the physiology behind the RV and how it differs from the LV. The biggest difference, I think you can say, is that there's no isovolumetric contraction or relaxation. So what that basically means is that the RV doesn't really waste any energy in building up pressure gradients, unlike the LV. So most of the energy is really just about keeping the momentum of the blood going through the RV into the low resistant lungs. So for this reason, the RV doesn't really handle pressure well, but it can really take a lot of volume without feeling the burn, so to speak. And it also uses up probably 1/6 of what the LV does, and that's because it doesn't really waste energy doing this. It's just basically acting more like a passive conduit for the blood. So small changes in pressure can really drop the RVEF, in contrast to the LV, which can usually handle pressure changes very, very easily and less dramatically than the RV.
Thanks. That was great. Yeah, I think one of the interesting things when I was attending a conference on RV and LV function, one of the questions they asked us was, is the RV ejection fraction different from the LV ejection fraction? And it tricked people a little bit because, as we know, the RV ejection fraction tends to be a little bit lesser than the LV ejection fraction because, like you mentioned, the RV is a more compliant chamber, ends up having a larger end diastolic volume than the left ventricle, so much so that the stroke
Correct.
volume ends up being the same, but the ejection fraction is numerically lower. It's very interesting,
Right.
but it's something that is less commonly known, I would say, among
Right.
people.
Right.
So when we talk about RV failure, it's something that we do see fairly often, I think more in the setting of LV failure. But when we talk about just right ventricular failure, what is the typical clinical picture that you would expect? And what kind of symptoms do some of these patients experience?
Yeah, sure. So acute RV failure, these patients are sick. In general, the RV failure happens when you don't feel the LV and basically you lose the systemic output. So of course, hypotension is the big thing. So you're going to have low blood pressure. You can have dyspnea, you can have syncope, you can have arrhythmias, but basically the pathophysiology you think about is that you're hypoperfused. Basically, you're not filling the LV, so you can have all the signs of low perfusion, like tachycardia, cyanosis. Even you can have cool extremities. You may not hear much on the lung exam, and when you do hear something on the lung exam, it might point to the etiology of the RV failure rather than pulmonary edema. Generally, the lungs are protected from all of this because there's really just not much flow going through them. But if you do hear crackles or anything on the lung exam, that might point to a secondary lung process that's causing this, like ARDS or something like that. Third right heart sound is very common. You can also hear the TR murmur. And then if you think about the backup of fluid, where is it going? It's going to the gut. It's going to the liver. So you're going to feel hepatomegaly. You're going to see edema. You may or may not see ascites if this is acute, but that's something certainly you can. Hypoxia can be quite common, actually, because, if you think about it, 15% of the people have PFOs. So when your right-sided pressures increase, it's very common to pop open that PFO and suddenly you're having a right to left shunt, and that can make someone more hypoxic. So all of these things just point to elevated venous pressures, low systemic pressures, and the backup that comes thereof, including hypoxia.
Absolutely. That's actually a great description of how we've seen these patients present. And I will ask you a little bit about why it's important to know that RV failure is important in clinical practice, considering that a lot of what we see is left ventricular failure, and we treat it and we have treatments for it. But the morbidity and mortality associated with RV failure Could you tell us a little bit about that too?
Yeah, absolutely. So again, this is a highly morbid disease, and we know very well. You're right. We know how to deal with LV failure extremely well. RV failure has to be thought of completely differently, and there's a couple principles that I always kind of think about when I think about RV failure, isolated RV failure, taking the LV out of it. So we know with the LV, sure, you drop your afterload, you have to keep the systemic pressure nice and low. Not so with the RV. If you're thinking isolated RV failure, what I always tell the fellows, you really have to maintain a good blood pressure. You have to keep the MAP high, and there's a couple of reasons for this. One is if you think about RV perfusion, when does the RV get perfused during the cardiac cycle? And with the LV, the answer is obvious. You say, oh, well, it's through diastole. That's when the coronaries get perfused. But actually, with the RV, you're being perfused throughout systole and diastole. So, and that's because inherently the RV systolic pressures are much lower. So the perfusion through the endocardium of the RV happens continuously throughout the cardiac cycle. So the first thing that happens when you drop your MAP is that you're going to lose a huge, significant amount of perfusion to the RV, and that portends ischemia. So unlike the LV, where you say, well, drop the blood pressure, that'll make the LV pump easier. It's actually the opposite for the RV. You have to keep the blood pressure high so to avoid that RV ischemia. So that's, it's really important to distinguish the two because, one is treated with afterload reduction and the other is treated with actually vasopressors if needed to maintain a certain MAP. So it's very important to know the difference between RV and LV failure. And there's several, obviously, and I think we're probably going to talk about it in a little while, but there's several kind of clinical things that we can use to help us decide, RV versus LV, not just clinically, but hemodynamically, which is really the most important thing here.
Yeah, I think we'll go to that right in a second. So when you talk about RV failure, when you have a patient in front of you, what sort of diagnostic algorithm or a differential do you have in front of yourself? And then how do you categorize these different classifications? Because I'm sure it does affect how you manage these patients.
Yeah, of course. So, number one, is this an acute presentation or is this chronic? And that will kind of help you decide how worried you have to be, how preconditioned is the RV. The acute guys tend to be a lot sicker. The first question I ask myself is this an intrinsic RV problem? Or is this a problem of preload or afterload? The intrinsic RV problem issues are things like myocardial infarction of the RCA or myocarditis, which can affect the RV preferentially. And then there's several kind of acute RV issues that affect the actual muscle contraction. So that's really, in the chronic cases, you think of, long-standing RV myopathies or ARVD, congenital lesions, things like that. But again, the first thing is to rule out, is this intrinsic RV versus a preload problem, which would be volume. So did this patient just get 10 units of packed red blood cells? Are we volume loading him? Is there something about the volume that's changed in the last couple of days that would portend RV injury? The afterload issue are things like pulmonary hypertension. What is the RV pushing against? It's the lung. So is there pulmonary hypertension? Is there LV failure causing RV failure? You really want to, in the first 5 minutes, be able to kind of distinguish which one of these three pathways is this patient. Is this a preload issue where there's too much volume? Is this an afterload issue where the RV is pushing against high pressure lungs or a high left-sided pressures? Or is this an intrinsic RV contractile problem? And then you can kind of answer the questions of acute and chronic based on that assessment itself.
Thank you. Yeah. When you think about this pathophysiology of RV failure, like you mentioned, you can have afterload in the way of pulmonary hypertension or something else going on. Do you look at some of the reversible causes as well, especially in the case of pulmonary hypertension, and what we can do to reverse these acutely, because they can make a big difference in your patient's PVR?
Yeah, absolutely. So, acute things that can really damage the RV, if you think about what are the most potent vasoconstrictors of the lungs, you think hypoxia, and then you think hypercapnia. things like ARDS, and of course, hypercapnia, hypoxia, they're fairly easily reversible, and you'll find that the RV generally recovers very quickly when it's caused just by those two issues. So, things like ARDS, where you may not be ventilating well, or if there's a massive pulmonary embolism that's causing a high pressure. These are all acute cases that can be fairly easily reversed with just, offering oxygen support or ventilatory support to blow off the CO2. And of course, the PE is going to be anticoagulation and thrombolysis if appropriate. So, these are acute scenarios that can really dramatically and drastically affect the PVR that can be fairly reversible with the right treatment.
And when you see these patients, like you said, you're trying to differentiate the type of RV failure. What kind of tests would you order in a patient like this? What kind of imaging would you prefer to use? Do you prefer one over the other?
Number one, I think imaging can be a bit tricky. If you're thinking something like pulmonary embolism, the CT with contrast obviously will delineate a proximal clot or anything like that. And additionally, the CT of the lungs will give you an idea of ARDS and things like that. Now, sometimes in many cases, it's very difficult to tell what's the difference between ARDS and high wedge pressure. And for that, really, hemodynamics are going to be the predominant thing that will kind of differentiate those two states for you. But, you start off with the echocardiogram. You'll get a sense of what the RV function is, and it'll give you clues on acuity or chronicity of the event as well. The RV dilates out fairly quickly. They, in general, an acute insult to the RV shouldn't give you extremely high PA pressures. And that's just because embryologically the RV is not able to tolerate or able to generate such high pressures acutely. If you do see extremely high PA pressures right off the bat in your initial imaging, it tends to suggest that there's some kind of preconditioned RV where you're able to generate pressures like that. There's things on the echocardiogram you can also look at, like the TAPSE score, which is basically the movement of the tricuspid annulus. Mm-hmm. And that over 1.6 suggests pretty reasonable RV function, whereas if your TAPSE is under that, then that would suggest that your RV function is impaired. But generally, the echocardiogram is a great tool to be able to kind of distinguish acute or chronic and a general sense of the RV failure. But in reality, the echo is also a limited modality, and most of the time you should be combining it with hemodynamic parameters to really make an assessment.
And that brings us actually to this hemodynamic assessment. So most of these patients that present with acute RV failure, are they usually in the CCU, and do most of them have a Swan-Ganz catheter? How do you approach that?
They absolutely should have a Swan-Ganz catheter. Now, if they all do or not, that's it's pretty institutional dependent. But I find that if you're worried about RV failure, a PA catheter for management is imperative. And there's several different kind of parameters that have been come up with and different variables you can look at. Some are easier to calculate than others, but the biggest thing is the RA pressure, and I find that is probably, in my mind, the most helpful number that will kind of give you a quick snapshot as are you worried about RV failure or not? A CVP of over 15 or so, I would start to worry. A CVP of 5, I doubt this person has significant RV failure. And then more importantly is don't take the CVP in isolation. Look at the wedge pressure. CVP that's higher than the wedge pressure, that's not a physiological condition. The RA should never be higher than the LA. So if you do see that, then that should kind of raise your red flags and say, hey, there's something not right about the RV here. And of course, PVR is a classic kind of a number we look at where you take the mean PA, subtract the wedge, divide that by cardiac output, and a normal PVR is somewhere in the order of 3 or below. And that can also kind of give you a quick calculation in your mind of are you worried about the RV or not. There's other scores like the POPI or the PA pulsatility index, which will take into account the difference in the PA pressures, the systole minus the diastolic pressure over the RA pressure. And this marker can be used to predict RV failure after an MI, or particularly we use it a lot after LVAD just to try to predict. So a PAPI of under 1.85 is really what our cutoff for whether we'd be worried about right heart failure after an LVAD placement. So there's several different numbers that you can use and several different parameters. Some are easier to memorize than others, but in general, you know it when you see it. The RA pressure is higher than the wedge. You have low cardiac output combined with the clinical exam. That should kind of clinch your diagnosis of RV failure.
And typically when you're treating RV failure in these patients, let's say that a scenario that is not uncommon in these patients where you have a relatively low wedge pressure of around 10, you have a CVP of around 18 millimeters of mercury and a cardiac index of 1.8, which is low. What would your approach be to sort of starting off in the treatment of these patients? And then do you target these patients to CVP goals sometimes while you're managing these in the CCU?
Yeah, certainly. So again, a lot of how we manage depends on the etiology, which I'm assuming that you've kind of elucidated by now in the CCU with a SWAN in place. But the principles basically are the volume management is tricky. The CVP goal, we generally say, should be a little bit higher than you would see for normal patients. And that's because, again, the RV is, as we described earlier, more of a passive conduit. Therefore, you need to have a preload to kind of perfuse and keep the momentum of blood going through the RV. So our CVP goal is generally around 12 or so. Anything lower than, 10, I would start to worry that you're actually dropping your CVP too much. But again, volume management is tricky because how much preload is enough. And with every RV, I think it's a little bit different. But in general, you want to keep the CVP somewhere around 12 in RV failure. So again, how do we do that? We use diuretics. Diuretics is also, it's going to be a little bit difficult in isolation because your wedge is 10. How much diuretics can you really give to this patient? So you really need to start thinking about how can I improve the RV contractility. We have several inotropes here that we use to optimize RV failure. Some you have to think about either dobutamine or milrinone. And dobutamine has the benefit of not dropping your blood pressure too much, which is, we mentioned, very important in RV failure. Milrinone has the added benefit of not only inotropy, but also pulmonary vasodilation, which may be helpful if you're dealing with a case of pulmonary hypertension. But that's, the RV contractility part of this that we have to think about as well.
Mm-hmm.
It may not be enough just to diurese. I think you're going to need RV inotropy as well.
That's true. And the other thing you mentioned before, which was absolutely true, was maintaining a high MAP in these situations because the septum forms such a large part of RV contractility that realigning the septum to the middle and sort of geometrically optimizing the right ventricle probably plays a good role in the acute management of these patients.
Oh, sure. It really definitely contributes to stroke volume of the LV in a significant way. So you really want to kind of try to maintain that geometry, and you do that with volume optimization plus inotropy.
One of the things I have noted in some of these patients is now they have a cardiomyopathy. Not uncommonly will they have arrhythmias accompanying this, most commonly atrial arrhythmias. What is your approach typically to someone who's being managed for, let's say, acute RV failure on inotropes and pressors while you're diuresing? If they are in atrial fibrillation or atrial tachycardia, how do you manage some of these patients?
Yeah, so this is actually, we see this all the time, and I'm glad to bring it up because one important thing to remember about these patients is that they really don't tolerate atrial arrhythmias at all. And you'll be surprised, even if it's rate controlled, say AFib of 100 is hemodynamically significant in these patients because they have they're really dependent on that atrial contraction to contribute to the preload. So it's I try my best to keep these patients in sinus rhythm, and of course their CVPs are 20 and they have low indexes and they're on inotropes, so it can be very challenging. But as much as we can, We use the tools available like amiodarone, DIG plus or minus, but there's definitely a conscious push to try to maintain sinus rhythm in these patients, knowing that atrial contraction, that atrial kick is very important for RV output, and in general, any kind of arrhythmia, atrial arrhythmia, is not tolerated in these patients.
True. And a significant proportion of these patients end up being on a ventilator in the ICU for one reason or another. Like you mentioned, they may have ARDS or respiratory pathology that starts everything. Does the ventilation itself have an impact on right ventricular function and right ventricular stroke volume? And how do you approach ventilation management strategies here too?
Yeah, so this is an important thing to think about, and it's best described as really just a fine balance here, because the ventilation, obviously, we mentioned the two most potent vasoconstrictors in physiology is hypercapnia and hypoxia, both of which the ventilator can address and actually reverse. The unfortunate part of this is that it's positive pressure, and positive pressure by itself adds to the afterload of an already sick ventricle. That can actually be hindering you from progressing. So it's an extremely tight balance. So what we try to do is we say we limit our tidal volume, we limit our PEEP, we limit our plateau pressure, and hopefully we can kind of squeak by with early extubation. And again, the goal is to maintain hypoxia and minimize hypercapnia at the same time at the lowest possible pressure for the RV. So it is really, there's no easy solution out of this, but it can best be described kind of this balancing act between, preserving oxygenation and gas exchange while at the same time minimizing pressure that the RV is going to face.
One of the things I think I also wanted to just ask you is the role of pulmonary vasodilators in a patient with RV failure. Do you use it often? And if you do, what mode? Is it inhalation that you use, IV? Do you use pills? What's something you prefer?
Yeah, so again, once you've established that this is a pulmonary afterload problem that's really causing RV failure, the important thing is you have to show that there's a low wedge, because if you try to introduce pulmonary vasodilators with a wedge of 30, you're setting yourself up for disaster, and that can even exacerbate the condition. So you establish that this is a primary cause. You're targeting a mean PA. You have a couple methods that we've used, and what some are better than others, but the most common tool we use in the ICU is inhaled nitric oxide. Inhaled nitric oxide works through cyclic GMP. It's actually cyclic GMP is the second messenger, and that's the vasodilating substance. That's where the money is, and so that's really what you're promoting when you deliver inhaled nitric oxide, and it's a very good pulmonary vasodilator. And the therapeutic range is somewhere between 0 and 20 parts per million. The most benefit you really see from 0 to 5 parts per million. So that's really where you get the most drop in your PA pressures at these ranges. So that's one option. We use inhaled nitric oxide. The second option we've used is inhaled Flolan or prostacyclin. Now, prostacyclin is a direct vasodilator of the lungs, and we've used it very successfully. And in fact, I think it's about a fraction of the cost of nitric oxide. So in that sense, it's probably preferable with the same efficacy as nitric oxide in lowering your PA pressures. So those are really our two options. They're both inhaled, and the idea is that you minimize systemic vasodilation, which again is important for RV failure, and you maximize pulmonary vasodilation.
Oh, that was great. Thanks. Yeah. So I think most of the patients are probably going to be able to be stabilized with all the modalities that we just spoke about, really medications and hemodynamic optimization strategies. If you have a patient that is really unfortunately just not responding adequately to the different modalities we spoke about, what other options do you have for RV management in these patients?
Yeah, so this is tough, because really now we're talking about the pumps, and the pumps are great as a bridge to something, either recovery, hopefully, but ultimately we don't have options to really actually viable options to go home with implantable pumps. So they really are used in certain cases as a way to kind of coax the RV back. Sometimes you just need a little bit of time, but we have a couple options for RV mechanical pumps. Things that can be placed easily in the cath lab. We have the Impella RP, which is basically placed through the groin and goes up basically to the PA, and the inflow is it pulls out from the RV and dumps out to the PA, and it's basically used just as univentricular support. Next, we have the tandem RVAD, which is actually placed through a transeptal puncture, and that's actually also placed percutaneously. We have different methods of doing kind of this VV ECMO kind of configuration where it's really offering just right ventricular bypass. And then ultimately, really, it's VA ECMO is the big gun. And that's basically when you want to put something in 10 minutes or under, you can do this percutaneously, or you can, actually do this surgically, but it's basically complete bypass for the RV and for the lungs. And, there have been cases of putting in implantable left-sided pumps like the HeartMate 3 or the HeartWare to the right side, the RV configuration. But in reality, these pumps were not designed for low afterload situations. So it's really not optimal, and there have been issues with management of these pumps in the right-sided. But in theory, it's been done. It's been well published in the literature. And these are, there's several case reports, but they're really not what the pumps were designed for.
And just like you mentioned, since we don't have any durable options for RV support for which patients can typically be discharged on and can be ambulatory outside in our communities, heart transplantation seems to be one of the only options we can offer to these patients. How do you approach your durable heart transplant options in some of these patients? And in the current allocation system, which is fairly new, do you think these patients can be offered an advantage in some way, or are they disadvantaged in some ways?
Yeah, I think, with RV failure in general, we don't have a lot of mechanical options for home support. So in that sense, this new system favors the RV failure patients because really you're stuck in the hospital and you're stuck on pumps, which automatically is a status 2, which is in the new system. And I think, for the sickest patients with RV failure in the hospital as a status 2, I think this is a better system for them. It really does try to prioritize the organs to the sickest patients in the hospital. And so I do think that there may be an advantage if there is no bailout strategy, meaning that the RV does not recover. Now, of course, we have to think about these are going to be very sick patients to take to transplant regardless. Anybody with a mechanical pump, whether percutaneous or implantable, is going to be, is going to have issues with bleeding, coagulation, and the general inflammatory response that happens with these pumps. So in general, it's a higher risk surgery, but in a way, these patients will not have to wait as long as I think in the previous years.
And I think that brings us to the next question. At least in my training now, have had the opportunity and the advantage of being at a center which is able to do heart transplants. So when there's patients out there at hospitals that don't offer transplant, or some hospitals that may not be able to offer mechanical support options, how would you recommend physicians tackle those patients? And do you recommend these patients be transferred or treated at only select institutes with these opportunities are available, with these treatment options are available eventually?
Yeah, so, the one thing that we've established is that this diagnosis of RV failure carries an extremely high mortality, even in the best of hands. So I think the first thing that any kind of referring hospital or institution has to do is recognize RV failure, which it isn't always so straightforward. So that's really the big thing. Recognize RV failure and quickly act on it. Inotropes, and don't wait until the lactic acid is 10, 13 before you think about pumps. We kind of have to be very proactive with these patients. And I always say early referral, even if you're not sure. A little bit of RV failure, you think, oh, probably will be okay. These patients get sick very quickly as the hemodynamic changes in the lungs happen. A little bit of hypoxia, a little pneumonia can really turn these people into stable RV failure patients to acutely crashing RV failure patients. So the best, advice I would say is that, once you recognize that there's RV failure, or there's any bit of RV failure, get them to a center that can offer these advanced pumps and things like that. Once you start going down the road of lactic acidosis and shock, it's just a very difficult scenario to get out of, and the mortality is through the roof at that point. So I think early referral, early transfer out, whether all we'll do is put in a swan and start inotropes and that's it. That's okay, but at least the options are there.
Mm-hmm. That was great, Dr. Murthy. I think that was a fairly comprehensive review of really acute RV failure, the diagnosis, the testing, and management. And I'd like to thank you for that. That was really great.
Yeah, no problem. That was fun.
Do you have any final statements? Anything else you'd like to tell us? Any plugs?
No, I think this is going to be an evolving field. In the next 10 years, I'm sure there's going to be kind of this surge of mechanical options and mechanical supports and pumps and maybe even durable things to go home with, along with newer therapies for pulmonary hypertension, which is truly my passion. So I think we're going to see a lot coming in the future as far as more options to treat this. But in the meantime, I think the most important thing here is that we talk about it and recognize it.
Thank you so much, Dr. Murthy. Thank you for your time.
Sure, no problem. Thank you.
That was the end of another episode that we had a lot of fun creating. Thank you for listening. We really appreciate it. Please do like and subscribe because it means a lot to us and it helps other listeners find us. You can leave your suggestions for topics, critiques, things we can do better. You can email us at heartsuccessteam@gmail.com. Reach us on our website, heartsuccess.info, our Facebook page at HeartSuccess Team, or my Twitter handle, CardioBro. Thank you, guys.